Okay, so dear all, it's our pleasure to start this new webinar, and I'm Gaëtan Nocturne from the disease group Sjögren disease, and I'm here with Coralie Bouillot. Coralie, let you introduce yourself.
Thank you, Gaëtan. Good afternoon, everyone. So my name is Coralie Bouillot. I'm a patient representative in ERN ReCONNET disease group, working with Gaëtan, Chiara Baldini, and my colleague Anna Vieira. Happy to be there today for this very interesting topics, even for patients.
And so, yes, it's our pleasure to introduce Dr. Yann Nguyen, who will present us during this webinar the very important subject of heterogeneity in Sjögren disease. So, Yann, it's our pleasure to hear you. Just a quick reminder, if you had any question after or during the presentation of Dr. Nguyen, please add the Q&R system, and we will pass the question to Yann at the end of the webinar. And if you need, you can activate the subtitles for translation during the webinar. So, Dr. Nguyen, up to you. The floor is yours.
Thank you, Gaëtan. Thank you, Coralie. It's a pleasure to be here with you. I would like to thank the European Reference Network ReCONNET for this invitation. And I am pleased to present you a presentation about the heterogeneity in Sjögren's disease and the role of stratification and clustering. So I'm Yann Nguyen. I'm an associate professor in Paris University and in internal medicine. And I've been doing my research with Gaëtan and the team from Xavier Mariette and Raphaël Serror in Paris on Sjögren's. So I do not have anything to disclose. So I would like to start my presentation with a few patients that I had recently. So the first patient is a 26-year-old female who was addressed for parotid gland swelling. It was intermittent, it was not always, and she did not complain about ocular or oral dryness. She did not have pain, and she did not have fatigue. She did not have any objective dryness, and she had some blood test abnormalities. She had high IgG levels, positive rheumatoid factors, lymphopenia. She had also some autoantibodies, SSA and SSB, and the salivary biopsy showed a focus score of more than 1. So she had an ESPRI score 2 and SDIAD 3, but she does not complain of dryness. This first patient is a very young patient, but she meets the ASIA-EULAR classification criteria for primary Sjögren syndromes because she has the suspicion of Sjögren syndrome according to the SDI domain, notably the parotid gland swelling. And she has all the criteria, 6 points, so she does have according to the classification criteria. So patient 2 in other patients, it was a man, 49-year-old male patient who complained of joint pain, dryness. He had also some skin involvement with purpura, shortness of breath, lymphadenopathy, glandular swelling. He had weight loss and fever, pulmonary involvement also. He had shortness of breath in this CT scan, and he has dryness with a Schirmer below 5 and an unstimulated whole salivary flow below 0.1. He had a lot of abnormalities on his laboratory tests, positive rheumatoid factors, cryoglobulinemia, low C4 levels, anticentromers autoantibodies, but also SSA anti-antibodies. He has also lymphopenia and a focus score of more than 1. He has an ESPRI of 7 and an SDI of 36, and these patients also meet the classification criteria for primary Sjögren syndromes. So the last patient is maybe another kind of patient that we meet in outpatient consults. She was a 52-year-old female who was referred to me for Zika syndrome. She has ocular and mouth dryness, pain and fatigue, no other organ involvement, no skin involvement, no glandular swelling, and Schirmer below 5, unstimulated salivary flow rate below 0.1, and SSR antibody positive. She had normal IgG score and a focus score of 1. So she had a lot of complaint of dryness, of fatigue, and of pain, but not a lot of systemic activity. And this patient is also classified as a Sjögren syndrome with 6 points in the last classification criteria. So all the 3 patients all have Sjögren syndrome disease. But however, those patients, they are very different, and they have everyone have different complaints, different treatment goals, and they did receive different treatments. Patient 1, for example, I treat her with short glucocorticoid course to reduce the parotid swelling. Patient 2, he had a lot of treatments, but finally he ended up having rituximab for treatment. And patient 3, she had symptomatic treatment with ear drops and symptomatic measures. But all those patients have Sjögren's disease. So this is how to represent that Sjögren's disease is very heterogeneous disease, because patients may complain of patient-reported outcomes, dryness, fatigue, and pain, but not all patients. And there's a lot of systemic manifestations that occur between 30 and 40% of the patients, and every organ of the body can be involved. There's also a risk of lymphoma, but all those patients are different. And I want to remind you that today there's no FDA-approved systemic disease-modifying therapies for the treatment of Sjögren's disease. And why is that so? Why do drug treatment fail in Sjögren's disease? And this is a very nice review from Susan Arendt and Enrique Bootsma for the considerations for treatment, trial design, and interpretation and clinical efficacy. But one of the reasons is because all those patients are very different, and we cannot make a clinical trial with so many different patients because we have to tackle this heterogeneity. This heterogeneity is a major challenge for treatment and clinical designs because all those patients deserve different therapeutic targets, and maybe we should use different outcome measures for all these patients to take into account all this heterogeneity of these patients. You know all about the CREST, the STAR, the new outcome measure criteria, who take several domains in a single outcome measure, but we need innovative trial designs and stratification approaches because it could enhance the success of new therapy in phase 3 clinical trials. This was an editorial published in the Lancet Rheumatology last year. So how do we do that? How can we stratify the patients? So here is all the patients who have Sjögren's disease, and what we can do with some algorithm, with the new technologies, IA, etc. We can separate all those patients with their similarities and to make what we call some clusters. But how can we do that? How should we stratify the patients? Which are the criteria that we have to take into account to stratify all these patients? And this is what we're going to see together, because there have been many suggested stratification criteria. I will start with the first kind of stratification, which was symptom-based. This was a very nice paper from Dan and the team of the UK team from Young File, who took the patients included in the UK PRSS cohort, the UK Sjögren's disease cohort, and they modelized based on 5 patient-reported outcomes: depression, anxiety, pain, fatigue, and dryness. This is what we see here. And depending on the levels of each of these subjective outcomes, they could classify all the patients with a cluster analysis. And what they made, suggested was 4 symptom-based clusters that we can see here. The first one was the low symptom burden, the patient who had finally not a lot of depression, not a lot of anxiety, low level of pain, fatigue, or dryness. The opposite was the high symptom burden clusters, patients who had a lot of these patient-reported outcomes. And after that, there was 2 other clusters. The third one with the dryness dominant with fatigue clusters, and the last one with the pain dominant with fatigue clusters. But the last one was not such dry clusters. So this is very interesting because we can classify all these patients kind of easily with 5 symptoms. And when we study what are the biological pathways underlying this heterogeneity, they found that these clusters, which were symptom-based, were different with biological pathways. The dry dominant with fatigue clusters had more B-cell hyperactivity and the highest prevalence of B-cell lymphoma. The patients who are in the cluster with high symptom burdens had inflammation, antioxidant response, and altered cellular metabolism. And the cluster with the pain dominant with fatigue, but not a lot of dryness, had a lot of inflammation, antioxidant response, and also altered cellular metabolism. So the dry dominant with fatigue was kind of different. But what was more interesting is that they reanalyzed some clinical trials. Here you can see the Joker trial, who compared the efficacy of the hydroxychloroquine of the Esprit, and the TRACTIS trial, who evaluated the efficacy on rituximab on the stimulated salivary flow. And what they found is that in the Joker trial, there was a clinically significant improvement in Esprit scores for the high symptom burden subgroup, but not for the other one, with a decreased in Esprit, which were statistically significant compared with placebo. But here we have very few patients, 18 patients and 14 patients in this study. In the TRACTIS trial, what they found is that there was no different significant effect on Esprit scores overall, but in the dryness dominant with fatigue subgroups receiving rituximab, they had higher unstimulated salivary flow, which was the main criteria from this study, and compared to placebo. So this was positive in 13 and 13 patients. This classification has been also evaluated in other cohorts, and Sarah McCoy in the US studied that in the US cohorts, and based on a few symptoms, the dryness, the fatigue, and the pain, she also demonstrated that there was 4 clusters: low symptom burden, dry with low pain, dry with high pain, and high symptom burdens, which was kind of similarity. So these 2 classifications are very interesting, but however, they are only based on symptoms. So it is unsure if they take into account the whole pictures of patients who has Sjögren's disease. Another approach could be the multi-omic approach. So I will just cite one paper. There's been so many papers. This team studied the transcriptomic, the genomic, the epigenetic, and the cytokine expression and the flow cytometry data combined with clinical parameters into a big model. What they found also 4 kind of clusters, but those clusters were a little bit slightly different. It was based on the expression of some genes, and the first clusters, it was 1/3 of the cohort. They found an overexpression of the genes related to interferon signaling. The second one had not discernible pattern, and it was similar to healthy volunteers, not a very discernible pattern, of pathological pattern. The third clusters had overexpression of genes related to lymphoid lineage, and the fourth clusters with a strong expression of genes related to inflammatory and myeloid lineage. So this is very interesting approach with a lot of data, transcriptomic, genomic, multi-omic data. And if we compared the 4 clusters, we find also some dissimilarities. For example, here it's a very low, but the cluster 2, here is the SDI, and we see that the cluster 2, which is more close to healthy controls, have lower SDI. What we find that the 4th cluster had higher SDI scores, And also there are some difference in complement, also in hypogammaglobulinemia rates. We found some difference based on T-multi approach. But this is kind of difficult in clinical practice. When I see a patient in front of me, I don't have transcriptomic data, I don't have genomic data, so I cannot say you are in the first or the third clusters, and it will take some more time to have all this data, and it's not routine biological parameters. So this is what we suggested in the paper published last year that we made with the French team, but also in the Necessity Consortium. We proposed a new stratification based on PROs, of patient-reported outcomes, but also with very simple clinical data, especially with systemic involvement and also routine biological data. This was published last year in the Lancet Rheumatology. So basically what we put in the models was the 26 variables. We put age at disease diagnosis, gender, race, but also the patient-reported outcomes contained in the domains of the ESPRI, DVAS for dryness, for fatigue, and for pain. And we also put some systemic manifestations, which were basically the domains of the SDI, the constitutional symptoms, adenopathy, glandular joint, skin, lung involvement, kidney involvement, also central nervous system or peripheral nervous system involvement. We also put some biological data that we usually is easy to have, such as rheumatoid factor, autoantibodies, SSA, SSB, anti-RNP antibodies, anti-centromere antibodies, anti-DNA, high IgG levels, monoclonal component, cryoglobulin, and low C4 levels. So what we found this time 3 different clusters, and this was replicated in the Paris-Saclay cohort and also in the ACES cohort, which were 2 independent cohorts. What we found that in the first clusters, we had patients who were a little bit younger, and all the Asian patients were in the first clusters. We found in the cluster 2 that it was 80% of women, so there was 20% of men. We found all patients from Black ethnicity in these clusters, and those patients had dryness. And it was not the case for the first cluster, who had lower levels of subjective symptoms. The third clusters had high levels of pain, of fatigue, and of dryness, and consequently the ESPRI score were a little bit higher. And when we see in the clinical involvement, we see that all systemic activity is more or less contained into the second clusters with general symptoms, lymph nodes, skin, lung, and kidney involvement, PNS, hematological, and SDI in high SDI scores. And the cluster 1 and cluster 2, it was low SDI score, and it was also explained for the biological clusters. There was not a lot of systemic activity in those clusters. And when we see the biological parameter, we see that the first clusters had a lot of autoimmunity and B cell activity signs, such as high IgG count, rheumatoid factors, but a lot of autoantibodies and low C4 levels. And the cryoglobulinemia was more in the second clusters, and some different autoantibodies which were associated with this disease, such as anti-RNP antibody or anti-centromere. So what we propose is a classification based on 3 different clusters. The first one was the cluster which we name B cell active with low symptoms, the BALS cluster, which for younger patients, more Asian patients with biological activity, but not a lot of dryness, of subjective symptoms, and not a lot of systemic activity. The second cluster was the high systemic activity cluster, the HSA cluster, more men, African ethnicity, dryness, and a lot of systemic manifestation, high SDI score, and some autoantibodies such as RNP or anti-centromere autoantibodies. And the last cluster were the low systemic activity with high symptoms, which were patients with high ESPRI score, but not a lot of systemic activity and no signs of B cell activation. So what we suggested is that the 3 different clusters had different evolution. For example, for the risk of systemic evolution. So we tried to, in the assess cohort, we have repeated measures, and so we could evaluate the progression of the SDI score according to the time. And what we see is that in the first cluster, the biologic active score, it was more and more active, and this was significant. In the other one, it reduced the activity across the time. It's maybe the signs of the first cluster being possible to evolve into a more systemic disease. What we see also is that in the first cluster, the symptomatic evolution was in the first clusters. What we see here in red is when the ESPRI score is more than 5, and there was more and more patients across the time. And on the opposite, for the other clusters, it was remarkably stable. The last thing what we saw is that the lymphoma is a very high risk in Sjögren syndrome, but in the third cluster, there was no lymphoma over a 5-year period. And in the second cluster, the most systemic cluster, this is where we found the most patients with lymphoma, with incident lymphoma. And we saw some patients in the first cluster, but very few patients in these clusters, and maybe later. What we what we do is also that we compared our clusters with the symptom-based stratification by Tan and Wang-Fai, and we see that there was some correlation. For example, for the high symptom and low activity cluster, we have a lot of patients with pain dominant with fatigue, or dryness dominant with fatigue, or high symptom burden, but it was not very correlated. So we found a very poor correlation. So those two stratifications are different and might be complementary. They evaluate two different things. What we do after is that we try to evaluate the pathophysiological pathways supporting this stratification. This is what we did recently with Gaetan, which published in the last days. So in the assess cohort, we had the chance to have biobanking at inclusion. So we evaluated some cytokines for T cell activation, B cell activation, but also we evaluated the interferon pathways. Thanks to some transcriptomic data, the interferon score, which was a score representing the aggregation expression of 5 key interferon genes, so we could have the interferon signature. So what we tried to do is to compare between the different clusters, and what we see is that we found higher IL-7 and TNF-R2 levels in the BALS and the HSI clusters, the cluster 1 and the cluster 2. What we found also for B cell activation pathway, that we found higher rates of CXCL13 levels in the first two clusters compared to the last clusters. We found also that there was more B cell activation in the second clusters with higher levels of beta-2 microglobulin and FLT3. And what was very interesting is what the interferon pathways. The interferon score was higher in the first cluster, and more patients had a high interferon signature based on the expression of these 5 genes. So what we compared is how was mediated this interferon signature, and we found that it was mediated by the type 1 interferon signature with higher levels of interferon alpha in the BALS and the second clusters compared with the third clusters. So this is basically what we found. We found higher signs of T cell activation in the first two clusters, higher B activation in the second clusters, and higher interferon signature in the first clusters. So what was suggested is, could the interferon signature predict the evolution of the first cluster into a more systemic disease? So this is what we tried to do by stratifying the first cluster into patients who had a high signature interferon and a low interferon signature. And what we found was very interesting. We found that the few patients who had the lymphoma in the first cluster, the B cell active with low systemic activity and low symptoms, they all had a high interferon signature in this first cluster. The second thing that we found, and you can see here on the right, is that when we evaluate the survival without new immunosuppressants, which is like a sign of disease evolution, because you need to give immunosuppressant for reasonable clinical symptoms. So what we found is that almost all patients who needed a new immunosuppressant in the BALS cluster had a high interferon signature. So if the patients had in the first BALS cluster, so biology active with low symptoms, but has a lot of interferon signature, this patient is maybe at risk of developing a more systemic disease. So this is what we suggest. So the three clusters, what we found is the two first clusters are quite different from the third clusters, with more T cell activation and more B cell activation, especially in the second clusters. And the low systemic activity and high symptoms had lower risk of developing both activity and also a risk of lymphoma. But what we also found is that in the BALS cluster, so patients who are biological active with low symptoms, they have a lot of type 1 interferon signature, and this interferon signature could maybe predict a more systemic evolution. So this is the first two studies that we did on these stratifications, but we want to do more. So what we plan to do is to better study the pathophysiology of these clusters and doing a multi-omic analysis of these clusters, not stratification based on this multi-omic approach, but based on our approach after looking at the proteomic and the genomic data. But what is very interesting is to reevaluate the clinical trials with this stratification to identify which targeted treatment could be suitable for different subgroups. If the patients are more in the first group or in the last group, does one medication is more active, depending on which outcomes, of course, but also on which treatment. So this is a very interesting question that we have, and we will be able to give you some data in the next months, hopefully. So to conclude, so Sjögren's disease is a very heterogeneous disease with a lot of different patients, but all those patients have Sjögren's disease, and we do have to take care of all these patients, but we have to find the suitable treatment for each of these patients. So there has been different stratification approaches, symptom-based, multi-omic approach, but other approach, symptoms, clinical and routine biological data. So all those approaches are very different. They're all interesting, but they show different things. They are complementary and they show different approach and different manner to think. This stratifications highlights different pathophysiology and maybe different treatment response. And future clinical trials may consider this patient's heterogeneity in both in the design of the patients, in the stratification of the patients. It has been the case for most recent phase 2 trials who selected patients in the third cluster, or in the first cluster, or in the second one, with different outcome measures, and it had been successful for the first time. So there are a lot of progress in the clinical trials in Sjögren's disease to hopefully find a very nice treatment. And I think that tackling this heterogeneity will allow us to give some personalized treatments, precision medicines, to give the treatment for all patients, but vary based on all the symptoms together. So I will thank you for your attention, and I would like to thank Gaëtan, of course, Raphaël and Xavier and Jacques Gothenberg, who are the investigators of the ACCESS cohorts, the rheumatology department of Bicêtre Hospital in Paris, the Necessity Consortium, and of course the European Reference Network ReCONNET for this invitation, and of course Gaëtan and Coralie for moderating this session, and I'm happy to answer your questions.
Thank you, Jan. Thank you very much for this really, really interesting presentation. We have a few comments in the chat regarding a couple of your slides, mentioning the difference in the origin of the patient you have presented. So one question, do the different diets and nutrients interact in the move and antigen response by local immune system? And does that could interact with influence the different races that you have presented?
So that's a very interesting question, and I'm very happy that it had been asked, because diet and nutrients do have a link between for the autoimmunity, for the inflammation. So for Sjögren's disease and for this precise question and for these clusters, I do not have the answers because we did not evaluate the diet of these patients, but we do not understand everything in autoimmune disease. There's some genetic parts, but there's also some environmental parts. And this is what we call the exposome. So everything that is around us, the diet, the pollution, the medication, the microbiome, and everything could influence on this disease. In Sjögren's disease, there's not a lot of data on diet and the risk of Sjögren's disease and the risk of aggravation and the phenotype of the disease. There has been one study about diet which was made by the UK team from Benjamin Fisher, who showed that a patient who had a Mediterranean diet had less risk of developing Sjögren's symptoms, but it was compared with healthy controls. When we focus on patients with Sjögren's disease, and to my knowledge, there's not a lot of study focusing on diets among patients with Sjögren's disease, but it could be very interesting things to do. It's methodologically kind of difficult to do because we have to evaluate the diet of the patients, but this is something that we definitely have to work on. And the other question was about the role of the nutrients and microbiota in different races, which may influence justify the different racing clusters. So it's a very interesting question also. For the race, I think it's a lot of to do with genetic background, because all those patients I did not mention, but they were all patients in France. So the environment was quite similar in these patients for climate, for example. But of course, it's not enough. And what I said earlier is that there is basically an interaction between the genes and the environment. So probably there's a link between everything. But to make it, prove it, it's kind of difficult to do.
Thank you, Jan. Another question on the same topic. Do you see, or was there any link between the presence of anti-RNP or even anti-SM and the African phenotype in your cluster number 2?
Yeah, that's very interesting question. I could go back to my slide, which I showed the different clusters. And this is true that the anti-RNP, anti-transformer were more in the second clusters. And the second cluster had all those patients who were from Black ethnicity. Those patients in this cohort not every patient who had from African ancestry had the anti-RNP antibody, but it has been suggested earlier that anti-RNP and antibodies are associated with a more active disease. But everything is in this cluster approach is everything's together. It's not all linked together, but they display a lot of similarities on those patients. And the second question was, no, it was anti-RNP and
anti-SM.
Anti-SM.
Anti-SM, okay. Yeah, anti-SM, I did not report it here. I did not select it in the model. To what I remember, there was not a lot of patients in this cohort having anti-SM antibodies.
Okay, another question, Jan. Don't you think that your cluster number 2 might look like what in the past has been called secondary Sjögren, given the positivity of autoantibodies in scleroderma or lupus?
Yeah, that's a very interesting question. So Sjögren's disease is an evolving path. So this is true that now we do not talk anymore less and less from primary and secondary Sjögren's syndrome. We talk about Sjögren's disease, whether it is associated with another disease. It's two different diseases, but Sjögren's disease is not a symptom from another disease. But for the study, for methodological issues, every patient did not have the criteria for other disease. So for these patients, no patient for this cohort, no patients had lupus, no patient has scleroderma. So patients who had anti-centromere antibody, for example, did not have scleroderma, systemic sclerosis, and patients who had anti-RNP antibodies did not meet the criteria for other autoimmune diseases such as lupus, systemic sclerosis, etc. But that's true. It's probably
Overlapping.
Yeah, overlapping. It's maybe those patients who had auto-antibodies, anti-centromere auto-antibodies. We know in different studies that there are more systemic, more pulmonary involvement, and they tend to overlap with other diseases.
Thank you. One last question, Jan. How many cases showing different autoantibodies over time were found associated with overlap autoimmune disease, considering then affected by secondary Sjögren's disease?
Yeah, it's a nice question. So in this study, we had two cohorts. So the slide that is present here was the Paris-Laclais cohort, and we only have one visit point. So I do not have the data for the evolution of these patients, unfortunately. But for the second cohort, the LSAHS cohort, so the question is patients developing other disease? The response is no or very few. It's a lot of patients stay in Sjögren's disease. But yeah, that's a very good question also.
And maybe, Jan, if I may, for a last question, because I think that this result with the 3 cluster may have really important clinical consequence in our daily practice and may modulate the way we can take care of patients and change the timing of the monitoring and the need for a new workup for the patient. So this asks the question of the risk of evolution transition from one cluster to another. Do you think it would be possible to add the answer? I think no, it's difficult to answer, but how do you plan to answer this?
Yeah, this is very interesting question. So I think it can very change the practice of our clinical practice, because if the patients so these are clustering process, which are complex statistical methods. But when we see a patient in clinical practice, we know quite easily in which cluster the patient is. Like the 3 patients I presented earlier, if after a few biological workup, we see that there's no signs of B-cell activity, there's no other organ systemic manifestations, these patients might be more of cluster 3, and after a few visits, a few years, we can be a little bit more relaxed about the risk of lymphoma, about the risk of systemic evolution also. And when we follow those patients, they very rarely develop systemic manifestations if they have no signs of B-cell activations. But I think this is for the 3rd clusters, so the high symptom burden clusters. But the thing is, the real question is for the cluster 1. So the cluster 1, if this cluster is going to evolve into the 2nd cluster, not systemic disease. So this is quite difficult to predict, to repeat the clustering process. But I think that, so of course, we should monitor these patients and be careful of every systemic manifestation that they have. But also the interferon signature, which is more and more done in clinical practice, whether it's the interferon signature or the levels of the interferon alpha, for example. And maybe it could help us to stratify these patients and to see this is patient 1 in the 1st clusters, but with high interferon signature. And these patients, we should be more careful because it will, he or she will develop maybe more systemic activity. We should think about giving treatment, but nothing is proven yet. But maybe those patients might evolve into a more systemic activity, such as cluster 2.
Thank you so much. Very helpful.
Thank you, Jan. I have spotted some, let's say, some patients in the participants of the webinar. I will ask you a patient question, Jan, if you don't mind.
Yeah, of course.
Do you think that that stratification work could be a quick answer to our unmet needs, which is no treatment for the disease, when you will have reanalyzed all the previous clinical trials? Do you think it could be guide your clinical practice, even for patients with low systemic activity?
Of course, yeah. So the 3rd cluster is we have to also find some treatments for all those patients, but I think it could be very helpful for the design of the clinical trials, because, for example, now if there's no stratification, we take all those patients in a single trial and we evaluate only one thing. The more outcome measure was the SDI. But it doesn't make sense for patient in the cluster 3 who has SDI at 2 to have less. It's not the point. So this has been done recently. And for example, I think I do have a backup slide. So this is not with the clustering approach that we did, but this is for the treatments for iscalimab. You know, the twin study, which has been published earlier, and this is one of the first studies who was positive outcomes in the phase 2 trial with the ianalumab also. And this was suggested in different stratifications and different outcomes. For example, the first cohorts, they had SDI with a lot of SDI, more than 5, but a lot of systemic activity, but also ESPRI score, a lot of more than 5, though it might be close to the 2nd clusters. And the cluster 2 were patients who had ESPRI score with more than 5, but a lot of symptomatic disease, but few SDI, but more cluster 3. And what they tried the same medication, iscanumab, in each arm, 2 different populations. And what they evaluated 2 different things. SDI in the first cohort was a lot of high SDI and a lot of systemic activity, and iscanumab did find the difference. And for the second cohort, what ESPRIT score was evaluated, so the symptoms were more taken into account, and they found that the ESPRIT score was reduced over time. So it's more about that stratification. Even if the same medication, maybe we should not take the same outcome measures for patients who are more systemic activity, for the cohort 2, for example, so the cluster 2, but and patients for the high symptom burden take more into account their patient-reported outcomes, their symptoms in the outcome measures. And I think this is something that is more and more done, and hopefully, and this is the case with the most recent trials, with this stratification, that we will finally have one or many treatments for Sjögren's disease patients.
Thank you, Jan. Thank you.
Thank you so much. So I think if we don't have other question, we can conclude this this webinar. Thank you again, Jan, for this brilliant presentation, and I'm sure that it will help us in our daily practice and daily life, understanding better how to progress in treating a patient with Sjögren disease. And I'd like to thank my co-moderator, Coralie Bouillot, and the organizer of the webinar, and from the ERN ReCONNET, and all of you for having being present during this webinar that you can relook after on the website. So do not hesitate to have a look and to share this webinar of the ERN ReCONNET network. Thank you to all of us for your participation.
Thank
Thank
you
you very much to you too.
Thank you. Bye.
Bye.
Bye bye.